Good morning, everyone. Thank you for taking the time to attend to this lecture. Today I will talk about molecular biomarkers in cancer. I have no disclosures. All the work that will be presented today has been supported by grants and awards, some of them shown here. Well, before talking about molecular biomarkers, I must say that this has been a journey. Back in 2015 at the USCAP, we started talking about the role of the pathologists in the precision medicine era and um, uh, different congresses and pathology meetings have highlighted the role of next generation pathology, the technological advances in anatomic pathology and other fields. This presentation is actually an institutional experience. We have a research pathology team embedded in an Institute for Precision Medicine. So I will talk about the infrastructure and go quickly to some highlights of the technologies and platforms, highlight some of the research projects, and how these findings in patients that are enrolled in precision medicine are discussed in a precision medicine conference, more like a molecular tumor board format. Finally, I will highlight our research autopsy program and all of this, what it has served in the last few years for education and patient. So this is the precision medicine research structure at Weill Cornell Medicine. We have 6 pillars shown here. One is the research pathology and cancer genomics. And there are colleagues in different areas, clinic and the lab, obviously computational biology innovation, and the organoid team that are part of a wheel or multiple wheels that support different efforts, like I just mentioned, the research conference or molecular tumor board, research use only assays, spatial omics, and so forth. One of the important things is that all these programs support research fellowships, and if there is a discovery, we support clinical trials, physician-initiated clinical trials. All of these departments support this infrastructure. So here are a few examples of the 5 of these pillars. Spatial omics. Talk about biomarkers in situ. We have a platform that is the imaging mass cytometry or Hyperion, where you can multiplex up to 30 antibodies that are tagged to metals. And if you need more than 30 antibodies, well, you can design 2 panels to have up to 60 and so forth. The first experience that our institution had was describing the the protein changes that occurred in lung affected by COVID. So that was the first one of the first papers. And then what it did under some collaborations was to study different tumor types. So one of them is upper tract urothelial cancer, specifically in the metastatic setting. And these patients, I will convey the more details about this cohort, were consented to precision medicine. And here we have a couple of examples. One, a patient, 72-year-old male patient with metastatic upper tract. He was treated with immunotherapy. And after receiving the immunotherapy, there was no evidence of disease. The patient has like more than 7, 8 years with no evidence of disease. In contrast, we have a similar patient, 79, with the same disease. He also had bladder cancer. He received the same treatment, and unfortunately, he progressed rapidly and died. So what we applied was to the in silico analysis or the convolution of an already data set that we had in bladder cancer. All these gray bars are bladder cancer cases, and the darker bars are the metastatic upper tract urothelial cancer. And in bladder, we know that there are like T cell depleted cases and T cell inflamed. But in metastatic upper tract urothelial cancer, this is not, them are depleted. So we examined these samples from 44 tumor samples from 28 patients using this technology, the imaging mass cytometry. And what we observed, what not surprising, is that the patient who responded to immunotherapy had an immune inflamed tumor in contrast to the other and most of the other ones. So in the context of biomarkers of cancer, we can say that the T cell inflamed subtype of upper tract urothelial cancer may predict exceptional response to immunotherapy, even in the absence of high tumor mutational burden or microsatellite instability, like that was the case. The same kind of concept was applied to metastatic colorectal cancer. We studied 31 patients, tumor samples from 31 patients, performed the deconvolution in silico, the bulk RNA sequencing, and then applied the in situ examination um, by Kyrian, and observed that there was a difference between the patients who had an activated immune microenvironment, especially those with activated dendritic cells. Those were associated with an improved survival. So this could also be an important biomarker in these metastatic colorectal cancer patients. Now, that takes me to the next topic, which is the tumor immune microenvironment. We analyzed a couple of cohorts of different tumor types by whole exome and RNA sequencing. So we can see here now we have the capability to not only have the sequencing, integrated analysis, but also the prediction, potential description to immunotherapy, thanks to the robust algorithms that we have using artificial intelligence modeling. In this particular cohort, we analyzed 504 metastatic castrate-resistant prostate cancer. We performed whole exome and RNA sequencing, including 124 from our own institution. And the bulk RNA-seq data was publicly available data. And two algorithms that have been recently described. One of them actually it's an abstract were applied. This is novel deconvolution bioinformatic pipeline, and we came across different tumor microenvironment portraits for this disease, for metastatic prostate cancer. Not only that, it can be expected, some of them were immune desert. I mean, like prostate cancer is supposed to be a cold tumor, but there were also some immune enriched subset of these tumors. And more importantly, some of them had a better prognosis than others. So in the context of molecular biomarkers of prostate cancer, this can be also applied for prediction of prognosis. Now, the cancer cell specific portraits is analyzing not the microenvironment, but the correlation with the mutation portrait. And that was quite interesting because the high inflammatory NF-kappa B signaling did not exclusively cluster in the immune-enriched TMEs, in the tumor microenvironments. And in the neuroendocrine prostate cancer, which is a lethal variant of castrate-resistant prostate cancer, this in the metastatic castrate-resistant prostate cancer exhibits remarkable heterogeneity in the tumor microenvironment that is largely independent of tumor-specific gene expression. Um, this is another example of moving to a different topic, which is the research use only assays and the molecular tumor board that is actually a medical education approved conference. Mm, this is a case of 70-something-year-old male with history of bladder cancer. He underwent cystoprostatectomy about 5 years ago, and then he had a pathologic fracture. He had the femur and the ulna broken. And when he had the radiological studies, they noticed not only the fractures, the pathologic fracture, but also a small lesion in the lung. So with the pathology, I'll show in a minute. It was limited the information that we could provide morphologically was compatible with a urothelial cancer, urothelial cancer, but a lung primary could not be excluded. The patient, based on this history, the clinicians more likely metastatic bladder cancer gave carboplatin and gemcitabine to the patient and radiotherapy. The patient did not improve. So we face this diagnosis like very often, or the situation, which is a cancer of unknown primary, because you know exactly where the cancer is coming from. In this case, is it bladder, or is it lung, or from somewhere else? And it's a relatively common. We see it like in 3 or 9% of all cancers. The prognosis is poor, with median survival of about 9 months. And as is obvious, I would say the identification of the primary tumor, the therapy could improve the survival of these patients. Not knowing from this coming from, it's very challenging. Now, if we applied integrative whole exome and RNA sequencing platform like the ones that I presented with the tumor immune microenvironment, that could also not only predict the site of origin, but also identify potential biomarkers, right? In patients with cancer of unknown primary. So this is one of the studies we have submitted this for the next USCAP meeting, and the manuscript is in preparation, where in collaboration with industry, we trained an algorithm, validated this in public data sets. I mean, these are thousands and thousands of cases with known diagnoses, and validated the algorithm with clinical samples with known diagnosis, and then applied this in a real world application, like this patient with a pathologic fracture of 51 samples. It had a relatively decent um, performance, but more important is that we were able in these 51 patients be able to detect the targets, right? In addition to the tissue of origin where it was evident. This case, going back to the patient with a metastatic analysis, said, okay, based on DNA and RNA, there is a high percent probability that is lung adenocarcinoma. And then, the analysis has a breakdown of other tumor types, but the top was lung. And it was not even, the bladder cancer was not even here. So the patient, we went back to the clinician, the case was presented in the molecular tumor board, and the patient actually received first-line therapy for metastatic lung cancer, and he received immunotherapy, ipi-nivo. And you can see here the progression. I mean, only 6 months after that, how the metastatic lesions resolved. The patient is active, went back to his activities, and he's recovering. I mean, he's responding to the immunotherapy based on the tissue of origin analysis of this case. This is a different case, and this is more like integration of clinical and research endeavors. So it's patient. She was 58 when she was diagnosed with a chronic myeloid neoplasm, and it was unclassified. The marrow was packed. There was nothing to. It was unclassified, basically, this type of disease. But the patient, like after 3 years after treatment, a stem cell transplant, prednisone, she was at high risk of developing acute myeloid leukemia. And the clinician enrolled the patient in research for precision medicine. And during this time, one novel gene fusion was identified involving SIK, this gene. Unfortunately, the patient progressed to acute myelogenous leukemia. So we partnered with Dr. Monica Guzman at our institution. She's one of the experts in the epichaperone analysis of tumor of cancer cells. And the epichaperone, the way I understand it, is like of proteins, including the heat shock proteins, that maintain the cell alive, the tumor cell alive. But if you have a drug that targets this epichaperone, the cell dies. So Dr. Guzman developed this FITC this assay to measure the sensibility of these cells to these targets. And we perform the assays on the tumor cells on the acute myelogenous leukemia from this patient. And I'm going to show you the results. You can see here on this side, there were two targets, potential targets for these cells. The SYK inhibitors, because of the gene fusion, have overexpression of SYK protein, and the inhibitors for the epichaperone. These two companies that make these drugs will reach out for compassionate patient, and only this company gave the drug. This is a drug designed for something else. It was not for cancer. And it was based on the in vitro response of the tumor cells to these inhibitors. And you can see here in this diagram how the white blood cells, only a few days after she started receiving the drug, went down, and also the myeloblast went down. The drug was sustained, and the patient 3 years after, I mean, continued responding for the Cheryl. So this is one example of, the integration, and in this case, the biomarker, in addition to the myeloblast, could be the detection of the fusion that is used as a marker. Um, and we're going to talk about now more RUO assays, applied to these to our patients. And most of the recent efforts have been whole genome sequencing. But why whole genome sequencing? It has opportunities for new discoveries. That's true. But if we think about what we don't see in the genome, the dark matter, I mean, the non-coding regions, they might be alterations, driver alterations in those non-coding regions in about 25% of tumors. So there is a possibility to identify novel findings as potential drivers. Now, the first, oh yes, we have these efforts supported by industry and also grants. But one of the first questions that we are asked when we present this data to the clinicians is like, no, whole genome sequencing, it takes too long, it's too expensive, and you require frozen tissue. That's not the case. There is a transition now into the whole genome sequencing to the clinic. There are a few companies offering already clinical grade whole genome sequencing assays. First, you can use FFP, archival material from pathology, to do whole genome. The germline, you can have tissue, blood, or even saliva. There are companies who send the kit to collect the saliva, and that's your germline required to do whole genome sequencing. There is a fast turnaround time. In our experience, is about 2 3 weeks. Once the two samples, the tumor and the germline, are in the lab, all sequencing and analysis takes, I would say, comparable time to target assays. And it's cost effective. I mean, if you have a whole genome sequencing assay right nowadays, it's very similar to a target assay with 500 genes. In the longer term, it is more cost effective because you have so many alterations that you can pick up by whole genome sequencing, including germline events, fusions, and so forth. These libraries here, these cohorts, we divide in our institute by research. We have probably a few more than 1,200, and also the clinical endeavors that we are prospectively doing whole genome sequencing in all tumor types. It's a pan-cancer cohort. We have identified novel events in what we have described novel entities, like the GLI1 rearranged enteric tumor, myepithelial carcinomas of soft tissue. These are obviously rare tumors. We have characterized male breast cancer. In these patients, always check for FGFR1 amplification. FGFR amplification is enriched in male breast cancer. A controversial entity, NIPNAC fusion hepatic carcinoma. And probably you will hear more about this entity in the next few years. It's not a intrahepatic cholangiocarcinoma. The reason it was called that before is because of the thyroid-like appearance. It's very, very distinct histologically. Thyroid-like, it used to be called thyroid-like cholangiocarcinoma. Is inhibin positive, and all of these tumors have NIPBL-NAC1 fusion. There is a female preponderance, younger presentation, especially those patients who have more aggressive disease. As I mentioned, they have some histology and gross appearance characteristic, and the alterations are completely different. I mean, you have these are like the hundreds of cases of intrahepatic cholangiocarcinoma from CBioPortal, MSK, and the International Consortium for Genomics. And this on the left side, you have the mutations in P53, KRAS and other genes that are characteristic of cholangiocarcinomas. And our study cohort is in this darker purple color, and they don't share any of the abnormalities. And we have several other molecular alterations that we will be able to present soon at the USCAP and in a manuscript in preparation. One of the examples that I'm going to present in a few minutes is the homologous recombination deficiency that is better. I mean, the classifier based on whole genome sequencing are probably better than the target assays that are out there. Oncology biomarkers in other diseases, like by whole genome sequencing, we have analyzed esophagogastric adenocarcinoma. One of the important biomarkers that we can see here are the novel gene fusions. This one, for example, is a pancreatic ductal adenocarcinoma that has an inversion in BRCA2, and this translates in an HRD positive phenotype. There's a novel fusion with this gene with BRCA1 in serous carcinoma of the ovary that also blocks, basically deletes the function of BRCA. And in addition to the loss of heterozygosity, can lead to HRD positive phenotype. This is an interesting fusion in metastatic breast cancer that impacts the hormonal treatment by on estrogen receptor. So there are a few novel things that can be elucidated by whole genome sequencing. Anytime that we have a fusion that can be um, validated by fluorescent in situ hybridization, we do that interchromosomal or interchromosomal with enough distance between the two genes. This is a story. I mean, speaking about biomarkers, a story that a few years, well, this in 2012, it was elucidated a fusion, activated fusion in breast cancer that was enriched in triple negative breast cancer. It was AKT3. And after this publication by a prominent group, some clinical trials started to be designed. Like, okay, and it is an unmet clinical need. So we reach out to the group and say, hey, we would like to see the frequency, have the positive controls that you have, and we design this fusion by FISH. And we screened hundreds of triple negative and breast cancer, and we didn't find any. So at the end, to make the story short, I mean, it's like anytime you see novel, you try to validate, and by orthogonal testing, and our favorite one is or preferred one is FISH. And there are other examples that our group has contributed to validation by this method. Even complex events that happen in the genome, when you have short read and long reads whole genome sequencing, you can validate by FISH, and it is utilized even in the current era of whole genome sequencing. Okay, so these are the few examples that I would like to share with you in the context of homologous recombination deficiency. So if you have a tumor with HRD, they are more susceptible to treatments like PARP inhibitors and platinum-based chemotherapy. This is a patient with metastatic castration-resistant prostate cancer. And by target assay, you wouldn't see it's a BRCA wild type, right? But still, the analysis, the classifier by whole genome sequencing gave us a high confidence HRD because there is a structural variant in RAD51B and loss of heterozygosity on the wild type allele. And if you see these bars here, the different colors, those are molecular signatures, single base substitution molecular signatures, and SBS3 is associated with HRD. All of this, when I talk about structural variants, those even especially the complex structural variants are invisible to. So the only way to visualize that is by whole genome sequencing. So this patient actually would have been missed. I mean, the clinician wouldn't have contemplated um, using PARP inhibitors or platinum base if they had used a target assay, not whole genome sequencing. This patient, 70-year-old female with metastatic high-grade serous carcinoma. There were no alterations in clinical relevant genes found by whole exome and RNA-seq. However, whole genome sequencing analysis identified high confidence HRD, and this is due to a novel fusion that interacts with BRCA1 in the DNA repair. The SBS3, the molecular signature associated with HRD, is also high, and that's also we're in the process of validating by FISH, but it has a high confidence HRD. Another example in GYN malignant serous ovarian carcinoma. It's interesting. This patient had a debulking surgery. Then she presented with peritoneal carcinomatosis. And then after immunotherapy, there is no evidence of disease. So we wanted to know what's going on in the genome of this tumor. And it was interesting to find that one of the commercial assays found a variant in BRCA2 of unknown significance, right? Also picked up in the germline. So we decided to do our own analysis by whole genome sequencing, and found that the different structural variants and mutational signature was associated with HRD, giving us a high confidence score for HRD. So it's high not by commercial assays, but by whole genome sequencing. This patient has high confidence HRD. Probably this is the opposite. It's a patient with a female with recurrent metastatic high grade. The patient received a standard of care therapy, carbotaxol. She had recurrence debulking, received again chemo, and had another recurrence. And unfortunately, she had worsening metastatic disease. The molecular testing didn't show actionable any targets. Well, probably the P53 and FGFR2 amplification, but that was back in 2017. But the BRCA analysis, there was no mutation, and the HRD assay that is commercially available one of them did not detect, it was negative. So we performed the whole genome sequencing of this patient and had a high confidence HRD score. This case was presented at the molecular tumor board, and we still have to follow up this patient because the clinician said that even based on research, clinical grade, but research RUO test, the clinician would consider giving PARP inhibitor to this patient based on the HRD positive test. This patient is 52. He's a young patient with metastatic prostate adenocarcinoma that he had metastatic disease at presentation. So truly hormone naive metastatic. The patient received abiraterone, then the resection, prostatectomy that showed invasion into the seminal vesicle and locally advanced disease, metastasis in the regional lymph nodes. And the patient didn't have evidence of disease after a few months. Didn't have any targets. This is a target assay, about 500 gene panel. But something that we found in this patient was a CDK12 rearrangement by whole genome sequencing. And is important because it has prognostic significance. If you see these bars are the PSA level on these patients when they receive with tumor patients with CDK12 mutated prostate cancer, when they receive PARP inhibitors, they don't, the PSA doesn't go too low, but a subset of these patients respond actually to immunotherapy. So it's important. This, like I mentioned before, this patient didn't have that result by target acid, but it was elucidated by whole genome sequencing. Another patient with metastatic prostatic adenocarcinoma. This patient had a extra prostatic extension, intensely PSMA avid lesions. It was most of the metastases were in the bone. We did this because the patient was, progressing and not responding to standard of care therapy. We did the first the target assay. You see 0 in a NGS and next generation sequencing of the clavicular lesion. And this patient had by whole genome sequencing an NBM1 rearrangement, which it's a target to PARP inhibitors and ENSA. So those were just a few examples. I mean, we are pro whole genome sequencing, and as I mentioned before, is making the transition into the clinic faster than expected. These are other examples I want to present about the integrated efforts with our fellows and special omics and more assays is the research autopsy program. It's a pan-cancer effort. We first published this experience in 2017. We have, since then, this is only the solid tumors part and a few of the tumors arising in the central nervous system. We have more autopsies. I mean, this is an outdated slide, but something that we can provide to advance knowledge in oncology is the the quality of the specimens. It's a high quality plasma and tissue specimens. These biospecimens can be interrogated by different platforms depending on the question, the tumor type. You can develop, as you're going to see in a minute, try to develop avatars, tumor organoids that they can be tested by different drugs. And you can also elucidate the tumor heterogeneity and the clonal evolution. We published these findings in bladder urothelial cancer previously. Also, more recently, the complex phylogeny of this lineage plasticity that happens in metastatic castrate-resistant prostate cancer. The most commonly known is neuroendocrine prostate cancer, the tumor after being with potent anti-androgen drugs. Sometimes they develop this neuroendocrine phenotype that is lethal. The survival is then 12 months. In this particular case, the patient developed a squamous cell carcinoma from the prostate, and when we are able to elucidate like different clones, like some of them become squamous, other adenos, and all of these alterations can be picked up in plasma. So biomarkers that can be developed even before the multiple seeding occurs, you can pick up actually that in plasma. The other example that we can use with all of these examples that I just mentioned are from research autopsies. These are two different autopsies from patients who died of metastatic castrate-resistant prostate cancer. One of them had the adenomorphology, adenocarcinoma. The other one was more small cell that I just mentioned, endocrine prostate cancer. So we can analyze the in situ by spatial transcriptomics and also by imaging mass cytometry, the platform that I mentioned before, the different proteins in situ. These are two examples of pediatric autopsies where we have characterized rare tumors in the pediatric population. One of them is a pleuropulmonary blastoma. And the other one is, it was thought to be a pleuropulmonary blastoma, but turned out to be a rare, unclassified embryonal tumor with a novel fusion. Something like that can be developed is the tumor organoid. We call it avatars. So these are like 3D tumors that can be tested by, different drugs. These are examples of metastatic pancreatic ductal adenocarcinoma. This is metastatic castration-resistant prostatic adenocarcinoma. And these are like the curves that you apply different drugs, they can out depending on the experiment that you are asking. These are highlights of what I call the what research autopsies extend the reach of precision medicine beyond life. Believe it or not, I mean, some patients and families actually reach out to us and say, we want to contribute to science. We want to donate the tissue after death. And it's very moving. We try, as much as we can, honor this will. So we capture all of these samples from multiple regions. We try to do, depending on the research project, different platforms like genomic, spatial, functional studies with the either xenografts or organoids. Um, and at the end, the program generates the research autopsy program data to try to understand treatment resistance and to identify new targets. Um, Organoids, the avatars. So these are examples of different tumor types. Some of them are easier to grow than others. We did study and present like, which ones are like the uterine, for example, they have a better performance in terms of growing organoids. But if you try to grow prostate, kidney, and pancreas, it's very, very, very difficult. The fluids, when we collect ascites, they're very rich in tumor cells, so they're better to build these organoids. Obviously, more so resections than biopsy, but we still try to do that when to implement this into the precision medicine pipeline. The role of pathologies is very important. I mean, we try to characterize the smears or the cell blocks of these organoids. And also in this paper, I mean, this is a preprint, but it's very telling in terms of the analysis comparing the tumor and the organoid, how they correlate, and also what experiments you can do with high throughput drug screening platforms that I showed before. These are the final remarks that I wanted to share with you. Well, as pathologist, is undoubtedly our specialty has evolved. We as pathologists are in the front line of oncology patient care. We live a new times, and this is a new generation of pathologists that we have to train. And our field should be called precision pathology. I would like to acknowledge all my colleagues at the Institute for Department of Pathology, Oncology, and Urology at Weill Cornell Medicine. Here I'm the head of imaging mass cytometry, and my colleagues in different institutions like the New York Genome Center, Isabel, Boston Gene, and Inocras. And lastly, I would like to thank the Asociación Iberoamericana de Patología Molecular for the invitation, as well as SynLab and other hosting institutions for this event. Thank you very much.